Hey everybody, welcome back. It is October 2023. It is a new series here on Synapse Care Solution, Pain, Stress, and the Neonatal Brain. We are going to be focusing on several different aspects of pain and stress in the NICU, whether that's parental stress or actually stress and pain that our babies experience through various experiences, parent separation, CPAP, you name it. And we're also going to have a special presentation on the outcomes that happen after babies are experiencing high levels of stress and pain. So I hope that you'll be with us all month right here on our YouTube channel. Do me a favor, if you haven't yet subscribed to our YouTube channel, press that button. You can also hit the notification bell and you'll be notified by YouTube when we publish any new videos. So it really helps us a lot and I appreciate you doing that for me right now. So hit the subscribe button. Let's dive into today's presentation. This presentation is from Dr. Rachelle Sey, who is going to share with us the findings from her dissertation work when she worked on her PhD. And she's going to share with us a little bit of background around toxic stress, and then some of the findings and outcomes that she found when she related stressful experiences in the NICU to outcomes in her unit. So I hope you'll enjoy this presentation. If you want to get exclusive access to any handouts, other resources, and articles related to the topics this month, click the link in the show notes below or scan the QR code right here on this screen and you'll be able to get exclusive access. We offer so much valuable free NICU education every single month and you don't want to miss a thing. So go ahead and click that link and I will see you at the end of this presentation. Enjoy. Bye.
Hi, everybody. Our next speaker is Dr. Rachelle Sey, who's going to give us a presentation on neonatal toxic stress. Rachelle has been a neonatal nurse for the past 18 years and a clinical nurse specialist in the NICU at Sharp Mary Burch Hospital for Women and Newborns in San Diego for the past 13 years. In this role, she co-leads the extremely low gestational age newborn and the neurointensive care nursery programs, as well as in situ simulation and debriefing. In addition, she manages a variety of quality improvement projects, as well as consults on complex clinical cases in the NICU. She enjoys mentoring clinical nurses through evidence-based practice and nursing research projects. She recently completed her PhD in nursing as a Robert Wood Johnson Foundation Future of Nursing Scholar from University of San Diego. So welcome, Rachelle.
Hey, everybody. Thank you so much for letting me speak on my dissertation topic. I'm excited to share what I've learned through my process. It's definitely been a journey, which actually started with Kathy asking me to be part of the conference planning committee for the 2018 conference. And I always do feel like things happen for a reason. And I remember sitting at that conference and listening to Mary Coughlin talk about trauma-informed care. And it really just piqued my interest into that topic. And it inspired me to look into more about toxic stress and how that impacts our babies after they leave our care in the NICU. And so I'm going to share on that topic with you. Pull up my slides. There we go. So as a clinical nurse specialist, really a large part of my role has always been rooted in implementing evidence-based practice strategies and interventions with my team in order to reduce the key morbidities and increase the percentage of preterm babies that leave our NICU intact without these major morbidities. And while we've seen a decrease in these major morbidities over the last decade, we are remaining concerned about the presence of minor morbidities that we're seeing in these neonates as they leave our NICUs. So I'm going to share with you my objectives. As I mentioned, I hope to share a little bit about what I learned with my dissertation, but I'll start with defining neonatal toxic stress and exploring the use of trauma-informed care approach in our NICUs, and then looking at exploring the impact of neonatal toxic stress on long-term neurodevelopment outcomes in our preterm infants in the NICU. So starting with the case for trauma-informed care, we know that the rate of preterm infants in the U.S. continues to rise. And in 2017, there were 1 in 10 infants in the U.S. that were born premature. Infants born prematurely can spend up to 4 to 6 months, if not longer, in our NICUs, as many of you are aware. And any type of unexpected or unplanned hospitalization can be traumatic for families and patients. But this is particularly the case for our babies in the NICU and their families as they experience multiple prolonged physiologic, social, and emotional challenges through their journey in our units. We also know that the development of the brain is highly dependent on experience, and infants in our NICUs are exposed to significant stressors and pain. And in fact, in a recent publication by Weber and Harrison, they identified that infants can be exposed to up to 70 stressful procedures or activities per day while they're in the care in the NICU. And this prolonged exposure to stress in the NICU increases the risk for adverse neurodevelopmental outcomes in these infants. Scientific advances continue to demonstrate that there is complex biologic connection between the social environment, the neurologic development, and long-term health. And decrease in the age of viability threshold, even down to 22, 23 weeks that we're seeing now in our NICUs, allow these more extremely preterm infants to benefit from our life-saving therapies in the NICU. And this is all while being separated from their mother or support person during a critical time of neurobrain development. And despite the advances in care that we have for our premature and hospitalized neonates, there still remains a remarkably high incidence of long-term neurodevelopmental disparities compared to the healthy equivalent term infant. And this is just a list of some of the minor morbidities that neonates experience potentially after being cared for in the NICU. This is some of the items that have been pulled from the literature and are described as the preemie phenotype or minor morbidities. So things such as motor delays or executive dysfunction, ADHD, learning disabilities, other behavioral problems, visual motor difficulties. These are some of the minor morbidities that these infants experience. Looking specifically at toxic stress, this is really used to describe the pediatric exposure to adverse childhood events, or ACEs, and their impact on the long-term health and well-being of the individual later in life. The ACEs study, which was conducted in 1995 and published by Filidi and colleagues in 1998, was the first study of its kind to really look at the relationship between these adverse childhood events and their relationship or experience on adult risk behaviors, mortality, and long-term health of adults. And what they found is that individuals who had experienced 4 or more of these adverse childhood events were more likely to have multiple risk factors related to leading causes of death in the United States. Additionally, the Center on Developing Child at Harvard University, which was established in 2006, looked at over the last decade, they've looked at the environment and have tried to raise awareness on the relationship of toxic stress that results from early life adversity and exposure to these ACEs and its impact on the developing brain. And they've actually published multiple white papers that really look at this impact on the environmental influences on gene expression through the study of epigenetics. And the American Academy of Pediatrics, as well as the American Academy of Nurses, has just published policy statements that really call attention to toxic stress and that we need to make this a top priority in order to improve the health of our population. So I've identified a couple of key articles that really show the impact of prolonged stress experience in neonates and its effect on short and long-term outcomes. So Smith and his colleagues assessed cumulative exposure to stress and found that early exposure to multiple stressors correlated with altered neurobehavior at discharge. And this was a prospective cohort study that looked at 44 preterm infants who were born less than 30 weeks gestational age. And what they found is that infants in the first 14 days of life had their greatest exposure to stressors, although this varied among infants. So some infants had more stress exposure than others. And what they found is that increased exposure to stressors was associated with decreased frontal and parietal brain width, altered diffusion measures, and functional connectivity in the temporal lobes. And they also found that there was altered motor behavior on their neurobehavioral exam. Provenzi and his colleagues in 2018 also published a prospective study that looked at the impact of early stress exposure in the NICU and its association to the telomere length. And stress was calculated. They looked at the total number of skin breaking procedures. So, how many heel sticks were done, how many PIV insertions or arterial and venous punctures. And they also looked at the amount of exposure the infants had with mechanical ventilation as a stressor. And what they found is that the telomere length erosion occurred in very preterm infants in response to pain and stress exposure. So Kong and his colleagues conducted a prospective exploratory study that looked at 50 preterm infants who were 28 to 33 weeks gestational age in order to investigate the effect of early life painful, stressful experiences on neurobehavioral outcomes prior to the babies being discharged from the NICU once they reached about 36 to 37 weeks gestational age. And in their study population, the infants within the first 4 weeks of life experienced 643 acute procedures on average, which averaged out to about 23 acute procedures per day. And then they correlated these outcomes with parent contact. So, specifically looking at buffering with holding, breastfeeding, and skin to skin care. And what they found is that increased exposure to pain and cumulative stress also contributed to neurobehavior outcomes. However, parent contact, specifically skin to skin and breastfeeding, positively influenced the way the babies habituated on their neurobehavior exam at the time of discharge. Through my coursework and my studies, I looked at defining what neonatal toxic stress is through the use of a concept analysis. And so within defining neonatal toxic stress and using this concept analysis, I identified antecedents, so the things that lead up to toxic stress, as well as identifying key attributes and the consequences. So, antecedents that I identified from the literature for neonatal toxic stress included there needed to be a traumatic event, such as an admission to the NICU for our families and our babies. And it occurs during a sensitive time period during neurodevelopmental growth. And then there's exposures to stressors, and it's prolonged exposure to these stressors or multiple stressors, with the number one stressor being maternal separation and exposure to noxious environment, which we know occurs in the NICU with increased noise and lighting, all of the medical procedures we're doing to these babies. Also thinking of unpredictable or variable caregivers when there's a lack of continuity in the nurses or the direct care providers, as well as sleep deprivation. So all of those are potential stressors that these babies experience. So I derived this operational definition of neonatal toxic stress. It's the prolonged activation of the brain's response to trauma in the absence of a protective, nurturing adult relationship buffer that results in an alteration in brain development and long-term health. And this is just a diagram of the concept analysis. So you can see the antecedents on the top, the traumatic event, the sensitive period of childhood development or neurobrain development, and the exposure to prolonged stressors and triggers, with the two key attributes of threat, which is the prolonged exposure to the stress and the activation of the stress response, and deprivation, which is the absence of a constant, loving, nurturing adult relationship buffer, which in the NICU is parent separation, may be related to parental role stress or decreased bonding, or just the inability to be able to visit. There's multiple reasons in the NICU why there's parents or significant other separation from the infant. And then these result in the consequence of potentially absent resilience, which is expressed as altered brain development and rewiring. And this may be expressed as mental illness or behavioral issues later, poor academic success, developmental delay, or abnormal neurodevelopmental outcomes. So, parent presence is definitely a critical piece, and it's quite profound how parent presence impacts how these babies do in the NICU. And maternal infant separation is a considerable stressor for neonates receiving care in the NICU. And when we think about it, for the most part, when an infant's admitted to the NICU, the primary care of that infant is transferred from the parent to the NICU caregivers. And even when we in the NICU strive to provide parent and family centered care within our environments, sometimes we aren't able to achieve that as fully as we would all like to see it. And as a result, there can be an altered parental role and subsequent parent infant separation, which might disrupt this buffering effect that the parent or an adult loving relationship has on the stress exposure that the baby experiences. And in a prospective cohort study, Reynolds looked at parent presence and concluded that infants who had increased parent visitation and who were held more often demonstrated improved short-term neurobehavior exam results using the NNS at term equivalent prior to the babies being discharged. So in order for us to really promote this adequate social connection and attachment in parents, we really need to find ways to minimize the separation as much as possible using a family integrated approach. In addition to parent presence, nursing continuity is described in the literature as being really significant to how these babies perform with their outcomes. And neonatal nurses do have a profound impact on the developing neonate and promoting parent infant interactions. As nurses, we spend a significant amount of time with both the families and these infants. And Hallowell describes that the nurse work environment was actually correlated with parent presence. And some of the key principles that helped to increase parent presence included having effective nurse manager support for this model and sufficient resources available to provide additional nursing support to facilitate parent presence and engagement. But we do know that there are barriers to parents visiting, whether they have other siblings at home. The visitation restrictions over the last pandemic have definitely not helped with fostering parent presence. And so we've had to come up with innovative staffing models. And some of those can be using a primary care nursing model, using team nursing approach, so that we can minimize the total number of nurses caring for these babies in order to provide more of a stable environment for these infants in the NICU. The nurse is also critical for implementing specific nurse-guided interventions that benefit the infant, including parent engagement, the healing environment, and promoting nutrition. So, specifically with encouraging early parent involvement and interaction with the infant. So, nurses are critical at working with the team to help get these babies held early with skin to skin, engaging and encouraging the parents to have involvement with their infant, whether it's through reading, touching, using the scent cloths that we use when the parents can't be there. So, finding ways to promote bonding and attachment. The nurses are also critical in providing a healing environment that minimizes exposure to excess noise, lights, and stimulation. And of course, nurses are critical in also promoting adequate nutrition, specifically through encouraging pumping and expressing breast milk and directly with breastfeeding. And some of the literature actually mentions that breast milk and breastfeeding can be an adequate buffer for toxic stress. So, when thinking of this model of using a trauma informed care approach, we look at how we care not only for the infant, but also for the families. And trauma informed care was first implemented on a large scale by the Substance Abuse and Mental Health Services Administration, which endorsed the belief that there are multiple dimensions of trauma, including physical and bodily, but also psychological injuries. And these can have lasting adverse effects on the well being and function. So, as we're interacting with our families in the NICU, we really need to realize that the impact trauma has on these families, these parents, and that reactions to a past trauma, whether it's a previous NICU admission or the loss of another neonate, or maybe it's just something else that's going on in their home environment or their personal life that's causing trauma. And these can actually exacerbate a current traumatic situation as it gets layered. We also need to learn to recognize signs and symptoms of trauma in people, that the parents as well as the people caring for these infants, because it helps us to standardize our care and bond with these infants, and it helps as well as with the parents. And then as much as possible, we can work on resisting re-traumatization or preventing a situation that represents a tolerable stress, something that may not cause harm, into evolving into a toxic stress or prolonged stress. Sanders and Hall actually, in their article, identified these 6 key principles for trauma-informed care. And I think it's really important for us to consider these, as we know that the NICU environment is very stressful and traumatic. We have lots of noise, increased lighting, lots of procedures going on, and sometimes unavoidable separation of the infants and parents. Yet this is an environment where we need to have these babies, these preterm infants, grow and thrive. And with these 6 key principles, it's important for us to create a safe, both physical and psychological safe environment for parents in order to build trustworthiness and transparency between the team and these parents. And peer support models have been also very successful in helping to come alongside these current parents with someone that's actually gone before them and had a similar situation. It's just very helpful in minimizing or aiding in support for the trauma these families are going through. And then we also need to work on collaborating mutually with families and caregivers with the team so that there's active choice and decision making. We need to empower these parents to speak up, provide choices for them to help with active decision making. And then the final one is really looking at not exacerbating some of the trauma by some of the biases or implicit biases that some of us have, or looking at providing equity versus just looking at equality, and trying to address some of the social determinants of health that may impact some of our families differently than others. So we've identified that the primary trauma that's experienced by our hospitalized neonate is the absence of separation from their mother or support person, and that the neonatal intensive care is an early life adverse experience that includes experiences of threat, which is this increased prolonged exposure to stress, pain, and deprivation, which is the potential absence or separation from their mother or support person. So the purpose of my dissertation study was to look at the relationships or explore the relationships between sociodemographic factors, exposures to stressors in the NICU environment, looking at stress modifiers and buffers, neonatal morbidities at the time of discharge from the NICU, and their relationship with 2-year neurodevelopmental outcomes. And I also looked at the risk for autism as an outcome as well for all infants born less than 32 weeks gestational age. The theoretical framework that I used to inform and guide my study was first Mefford's health promotion model for preterm infants. And in this model, Mefford uses the key principles of Levine's conservation principles of nursing theory. And one of the key components to Levine's theory is that an individual needs to adapt from one environment to another in order to fit in the environment in which they live. And Mefford took this a little bit further within the context of the premature infant in the NICU. And the admission to the NICU is a stressful environment that requires the preterm infant to adapt early and quickly to the extrauterine environment. And Mefford, when she tested this theory, used or identified that the nurse is really a critical piece to this adaptation process, not only for the infant, but for the parent, in order for the infant to achieve a positive health status at the time of discharge. And I also used the infant medical trauma and NICU model to inform my study as well. And within this model, there are 3 life experiences that are unique to the NICU that she proposes may influence the long-term health of the neonate. and that is stress, pain, and separation, all of which are potentially modifiable items or things that are within our control to minimize or eliminate in order to build resilience for these infants while minimizing detrimental effects that are related to this increased allostatic load that these babies are exposed to while they're in the NICU. And this is my specific research conceptual framework. So I looked at infants that were born less than 32 weeks gestational age and admitted to a large NICU. And I looked at maternal demographics as well as neonatal demographics. And in my conceptual framework, there's a straight dotted line to neurodevelopmental outcomes at 2 years of age, because we do know that these things alone can impact or influence long-term neurodevelopment. But I also identified proxies for both neonatal toxic stress exposure and stress modifiers, and included in my conceptual framework a curved dotted line, which indicates that there may be a relationship between the toxic stress exposure and these stress modifiers and how they influence neurodevelopmental outcomes at 2 years of age. So my overall research aims were, number one, I described my study sample. But number two, I really wanted to look at the relationships between each of these variables and their impact on motor, language, and cognitive skills at 2 years of age. And then my third aim was to describe the amount of variance in these neurodevelopmental outcomes, motor, language, and cognitive at 2 years of age as a result of these variables. And to do that, I used multilinear regression. So I conducted a retrospective cohort study looking at infants that received their care in a large 84-bed tertiary NICU in a magnet-designated women and infant hospital in San Diego. And these infants also received their 2-year follow-up visits from a California Children's Services high-risk infant follow-up program within San Diego County. I included infants that were born less than 32 weeks gestational age, admitted to the NICU, and had lengths of stay greater than at least 30 days. These infants also had to have completed their Bailey 3 exam at or near 24 months in the high-risk infant follow-up clinic. I excluded infants that had major congenital anomalies, major neurologic conditions, including cerebral palsy, seizures, seizure disorders, and surrogate pregnancies. And here you can see my list of variables that I looked at. I was limited to what I could extract from the health record, but all of my variables were informed by what I read in the literature. So many of the maternal and neonatal demographics are very typical demographics that we look at. And then the stress modifiers, these were the items that I identified as proxies for stress buffers, and that's time from birth to first hold, time from birth to first skin to skin, time from birth to first breastfeeding, looking at the time it took to achieve full enteral feedings, whether the infants were still receiving some amount of breast milk at discharge. And then I also looked at parent visitation, the average number of visits per day and the average number of visits per week. And then I also looked at the constant caregiver, specifically looking at nurses, and looked at the average number of nurses in the first week, the first month, and over the total length of stay. And then I identified proxies that I could pull from the electronic health record that represented stress exposure. So specifically looking at the total number of lab tests, tests and procedures, number of blood transfusions, the ventilator mode the infant was on at 36 weeks, corrected gestational age. And also, I initially wanted to look at bed location and duration to see if I could identify if there was a difference between a single patient room versus an open pod, but I was unable to sift through that to include that as a concrete variable. But I also looked at rehospitalizations because a hospitalization has been defined as a toxic stress event as well. So I was able to pull whether infants had been rehospitalized since discharge from the NICU as another stress variable. And then my outcome variables, I looked at the Bailey scales of infant development, specifically cognition, language, and motor development. And these were assessed during their 2-year visit at the high-risk infant follow-up clinic. And then I also, at that 2-year visit, they also have an autism screen using the MCHAT autism screen. So I looked at that relationship as well. So I used a lot of descriptive statistics to describe my study sample, but also looked at inferential statistics to identify and study my relationships, and then ended with a multivariable regression model to identify the amount of variance that variables contributed to the outcome measures. So I ended up with a sample size of 340 infants that met my inclusion criteria from this NICU. And you can see here the demographics. So about 45% were Hispanic Latino, and 32% white and not of Hispanic origin, and 12% were Asian Pacific Islander Hawaiian Native, with 7% Black or African American. The primary language for the study population was English, with 88 primarily speaking English, followed by 7% Spanish speaking. This was a highly educated sample, with only 11% having less than a high school degree. And insurance was split pretty evenly between private insurance and public insurance. And when you looked at the neonatal demographics for this study sample, the average gestational age was 28 weeks, and the average birth weight was 1.1, and the average length of stay was 73 days. It was evenly split between male and female patients. And then, as you know from working in the NICU, there's a wide variation between babies that are born less than 26 weeks and those born greater than 29 weeks. So I did end up stratifying my data looking at 3 different gestational age groupings, and you can see the breakdown there for infants less than 26 weeks in the study sample, those that were 26 to 28 weeks, and those that were greater than 29 weeks. So even though the overall length of stay in the NICU for this population was 73 days, it's no surprise to any of us, the length of stay was significantly longer for infants who were in the 22 to 26 weeks gestational age birth group, and then less length of stay as the gestational age group increased. Here's just an overall summary of the characteristics for the nurse-guided interventions and stress modifiers. So on average in this study population, the number of days from birth to first hold or birth to first skin to skin was almost 10 days. And the number of days from birth to first breastfeeding was about 36 days. And you can see the average number of parent visits per day averaged about 1, and the number of parent visits per week averaged out about 6.5. And then when you look at the total number of nurses who cared for the infant in the first week, it was about 12. In the first month, it was about 40. And over the total length of stay, there was 72 nurses that cared for these babies, which seems really high to me. And then looking at some breast milk at discharge, there were 62 infants who were still receiving some breast milk at discharge, which is actually low compared to what the normal breast milk at discharge is for the overall NICU population in this NICU. And then looking at environmental factors, you can see the total number of lab tests, blood transfusions, the days on supplemental oxygen all listed here. And this is for the total population. But as you also can imagine, the babies that had smaller gestational ages had longer lengths of stay, and they also had increased number of lab tests, blood transfusions, longer days of supplemental oxygen. So they essentially had increased stress exposure with decreasing gestational age. And then for rehospitalization since NICU discharge, there were 69 infants in the study population that were rehospitalized, and those fell within the middle gestational age grouping. Those that were 26 to 28 weeks gestational age had the higher rate of rehospitalization. And then looking at the follow-up outcomes for cognitive language and motor score using the Bayley-3, you can see the averages there. The average gestational age or corrected gestational age follow-up was 24 months. And all of these scores were above the normal cut score of 85, but there were significant differences, again, no surprise, between gestational age birth groups. And then looking at the relationships that I identified from this study, when there was increased maternal age, increased gestational age at birth, increased birth weight, and increased parent visits per day during the length of stay, these were correlated with higher cognitive and language scores at 2 years of age. And when there was increased length of stay in the NICU, increased number of days from birth to first hold, so it took longer for these babies to be held or put skin to skin or for their first breastfeeding, this was correlated with decreased cognitive and language scores. As the total number of nurses caring for the patient over the length of stay increased, the Bailey 3 cognitive, language, and motor scores at 2 years of age all decreased. And as parent visits per day during the length of stay increased, so did the cognitive, language, and motor scores, showing that nurses and parent visits were key variables in outcomes. The type of insurance and maternal status were associated with lower scores across all 3 domains. So infants who had private insurance generally had slightly higher mean composite scores on their outcomes. And then infants that had high composite scores when their mother was married versus single. Maternal education at level actually impacted language and motor scores. However, maternal primary language was not significantly associated with the infant's language score at 2 years of age. When I looked at my overall models, they accounted for really a small percentage, 23 to, or 24% of the variance in the cognitive outcome, but the variables that were statistically significantly influencing the prediction for the cognitive outcome were race and ethnicity, especially when compared to the white mothers as the reference group, and whether the infants had some breast milk at discharge, and the average number of parent visits per day over the total length of stay. Again, showing that race and ethnicity were significant as well as parent visits per day. The final regression model or model for language composite scores only accounted for 26% of the variance, but the parameters or variables that significantly influence this prediction were also race and ethnicity, as well as maternal insurance. In summary of my findings, sociodemographic factors influence long-term neurodevelopment at 2 years of age, specifically looking at race, ethnicity, marital status, prenatal care, and type of insurance. And parent presence in the NICU was an important predictor for cognitive outcomes at 2 years of age. And the total number of nurses over the total length of stay was correlated with neurodevelopmental outcomes. Of course, there were limitations to my study. First of all, it was a single center study, so results cannot be generalizable. And it was a retrospective study, so I was limited to what I could pull from the electronic health record. And I think a prospective study where I can focus on specific variables that are identified would be better suited for a future research study. And then with pulling the data from an electronic health record, I ended up with some incomplete or inaccurate data. And so some of the variables I initially intended to look at, I was unable to study those because they were either incomplete or I had some inaccurate data. So really, the stay in the NICU is an adverse exposure that these infants have. And so identifying modifying factors that influence these negative effects on prolonged stress in preterm neonates can lead to the identification of interventions that alter the trajectory of long-term neurodevelopmental outcomes from infants that are discharged from the NICU. And what my study has added is that parent presence is important in influencing long-term neurodevelopment, and also nurse continuity is an important factor as well. But further research is needed to identify the impact that parent presence or nurse-guided family-centered developmental care interventions, staffing models, or pain and stress exposure have on both short and long-term outcomes. And I will end there for any questions.
Thank you, Rachelle. That was an amazing amount of work and dedication you put into that research. And we will see if there are questions coming through from anybody.
I'm actually working on a continuation study now. So there's additional sites, other NICUs here in California that we're going to do a continuation study so that it's not just a single site. And we're going to look at fewer variables, some of those that came out as significant in my study, to look at across a couple different NICUs, see if findings were similar.
I found it interesting how different your demographics for your unit are from what I would anticipate ours being for my unit, just being in different areas of the country. It's neat to see that.
And those demographics in my study were definitely characteristic of San Diego in general. So yeah, it's another reason why the study findings can't be generalizable, because we all have different demographics across our units.
Okay, so our first question is, can you clarify if the increased number of nurses over the entire length of stay was associated with decreased or improved neurodevelopmental outcomes?
So as the number of nurses increased, the neurodevelopmental outcomes decreased. Their composite scores decreased. So as there were more nurses over time, meaning less continuity of nurses, it contributed to poorer neurodevelopmental outcomes.
So someone's saying, is this potentially evidence for primary nursing? And what are your thoughts on primary nursing too?
So I definitely am a proponent for either primary nursing or a team nursing approach so that we can minimize the total number of nurses that touch these infants over their length of stay. All of us have a different approach on how we feed a baby, how we change a diaper, how we interact with the infants. So I think by having an increased number of nurses interacting with these infants, it could be a potential stressor for these infants. The theory behind that is decreasing the number of nurses or increasing continuity would have better outcomes. But I do think that more research needs to be done to show that effect specifically.
Have you presented this information to your team yet, since they were part of this? And has that inspired them to change any of your care models or staffing models?
I've presented it to our SHARP Research Council, and a couple of the NICU nurses were actually there and they heard it. And so they were very inspired by what I found from our specific study results, and they want me to share it with our staff. But informally, of course, I'm rounding with staff and sharing what some of my findings were. And our unit practice council actually has taken on a project this year to improve the percentage of infants that receive primary care nursing, but I think we're actually moving a little bit more away from a primary care nurse model to more of a team nursing approach. And I think that we might be able to achieve better continuity with.
Since you just finished your PhD, do you recommend other NICU nurses pursue this type of higher education? When you learn these research skills, how do you use them at the bedside?
I'm always a proponent of lifelong learning. I never thought I myself would go back for a PhD. The opportunity kind of presented itself. And I think a lot of people still ask me, now that you have your PhD, what are you going to do? And my answer is, I'm just going to keep doing what I'm currently doing because I love what I currently do. And I think there's so much that I read articles differently now and bring information back to our unit in a different way because I just have a different lens at how I look at everything. And I definitely think even at the bedside, having a doctoral degree is really beneficial in how we, even the information we get at conferences or what we're reading, and how we can translate that into knowledge at the bedside and how we care for our patients. So I definitely think pursuing your PhD or a doctoral degree, whether it's a DNP or a PhD, is great for bedside nurses. One of our bedside clinical nurses actually did the PhD with me, and she was in my cohort, and I have learned a lot, and it's definitely changed the way I personally look at a lot of different things.
Any other questions for Rachelle? People are saying bravo, great job.
I talked about this at one of the community calls recently when I was talking about bias, but as we're also looking at primary care nursing in our unit with our unit practice council project, we're also going to start stratifying by race and ethnicity the average number of nurses. So we can see if there's any difference, whether it's an English speaking family or Spanish speaking family or by race and ethnicity. So we can help to minimize those gaps there as well.
What are your thoughts on standardizing nursing interventions to do?
I think in the world of the NICU, we try to standardize as much as we can. And as we have standardized protocols and practices, I think there's always still some individuality that we as nurses bring. And so I think it's hard to standardize every single thing that you do. But I do find that when we've had primary care nurses, specifically of our complex patients, they get to know those babies a lot better. And so they have a lot more, I think, sometimes to bring to the team as we're talking about different interventions or approaches because they've cared for that baby over a long period of time. And you can see the difference when a nurse has that baby for the first time and they just don't have that history. I think as much as we try to standardize our nursing interventions, I think there's still always going to be some level of individuality that the nurse brings to the bedside and to the patient.
I know I would
That
agree with
answered that question.
I would agree with you on some of those things that in my unit for the long-term patients, the nurses who consistently care for them, they know what is the best way that kid tolerates care and how to approach them. And so they're able to personalize, even though we have our standardized methods, then they can personalize it to that patient based on that patient's tolerance, knowing them from day to day. All right, so the next question is, what is your team nursing approach?
So it's still evolving, and we're working on defining this and revising our guidelines around primary care nursing and team nursing. So I don't really have too much to share with that, other than we would rather than have a primary nurse and a co-primary nurse, we're looking at developing a team of nurses. So whether it's 5 nurses on nights, 5 nurses on days, and this is your team of nurses that are caring for your baby versus just the one nurse or the couple of nurses.
Did you look at the intensity of pain and stress as well? And Charlotte is saying stress is a hard sell for the doctors in her area.
Yeah, stress, I think, is sometimes hard to define. Our developmental care committee at Sharp is actually looking at one of our nurses created this beautiful diagram on differentiating pain from stress, because I think a lot of what we do at the bedside as nurses is we like to treat stress sometimes with pain medications. And so we're really working on differentiating what is pain and what is stress in order to minimize some of the pain medications that we're giving infants. So that's something we're working on defining. I didn't specifically look at intensity of pain. It was going to be really challenging to pull pain scores from the electronic health record for the length of time that I was looking at for this study. And I still feel like sometimes the pain scores that we use in the NICU are subjective. So it's a hard variable for me to use in a research study. But I would say our physicians in our unit are actually pushing more for stress management of the infant and using some of the other neurodevelopmental care strategies versus pain. Any other questions?
I don't think there's anything else coming through. Thank you for an amazing presentation, all the work that you have done, and congratulations on your recent PhD. Let's see. Somebody's commenting, I agree, individualization is important. I think if those nurses communicate the patient's preferences, it really helps decrease variations.
Yes.
People are saying, great job.
I hope you really enjoyed this presentation with Dr. Rachelle Sey and our amazing panel, Lauren Heimel, and other members of our planning committee from the One Conference 2021. So if you enjoyed this presentation, be sure to hit the subscribe button. Tell YouTube that you want to see more videos like that. It really helps us out a lot. Also, don't forget to scan the QR code right here on this screen or click the link in the show notes below so that you can be notified about upcoming events and to get access to exclusive information, resources, and articles. And stay tuned all month for our series on pain, stress, and the neonatal brain. I'll see you next time.